Good evening, ladies and gentlemen. Welcome to this evening's inaugural lecture by Professor Anand Pandyan. I'm Professor Nick Foskett. I'm the Vice-Chancellor here at Keele University. And I'm very pleased to welcome colleagues from the university, from the local health professional community, and from the national academic and professional arenas. For this is a strong indicator of Professor Pandyan's far-reaching influence and reputation. Particularly, though, I'd like to welcome Professor Pandyan's family and friends. For inaugural lectures are as much about family and friends as they are about the wider professional communities, so a particular welcome. Tonight's lecture is the first in our programme of inaugural lectures in a series of 8 this year. As such, it's an important part of the university's engagement with its wider communities, both nationally and regionally and locally, and they are important to us. Inaugurals are a recognition of appointment as a chair at the university, but they're also a recognition of the academic distinction of the new professor and their contributions to research and scholarship. As such, I'm confident that tonight's lecture will give an impressive insight into some of the new ideas and insights that are emerging from research at Keele. Professor Pandyan trained first of all as an electrical and electronic engineer at the Coimbatore Institute of Technology in India. And he then worked for 4 years as a clinical engineer at the Christian Medical College and Hospital. He completed his doctoral training, though, at the Bioengineering Unit of the University of Strathclyde in Scotland in 1997. And prior to joining Keele in 2002, he worked as a postdoctoral researcher at the Centre for Rehabilitation and Engineering Studies, that's CREST, which is at the University of Newcastle upon Tyne. Having come to Keele in 2002, Anand was appointed to the position of Professor for Rehabilitation Technology in the School of Health and Rehabilitation in 2011. Professor Pandyan's specific areas of research interest are measurement in neurological rehabilitation, specifically non-invasive measurement of disability and control of human movement, modelling the relationship between disability and loss in function, and using technology to facilitate recovery in patients with severe levels of disability. His interest in spasticity related research began whilst completing his PhD, and it remains central to his current research activities, where he manages research projects in 3 main areas. And these are developing a better understanding of the pathophysiological basis of spasticity and its impact on people with neurological conditions, exploring the mechanisms for disordered motor control following stroke and cerebral palsy, and exploring the use of technology in facilitating recovery in patients with neurological disability. In his lecture tonight, Professor Pandyan will focus initially on the fundamental research that leads to the redefinition of spasticity, called the lumping, and then he will describe the steps being taken to subclassify the symptoms associated with the definition of spasticity, the splitting, hence the title of his lecture. He's going to conclude by exploring whether spasticity is detrimental in patients with neurological conditions or an epiphenomenon. Can I therefore formally welcome and introduce Professor Anand Pandyan, Professor of Rehabilitation for Health, and invite him to present his inaugural lecture, Defining Spasticity, the Slow Walk from Being a Lumper to a Splitter. Anand.
Thank you, Vice-Chancellor. Good evening, ladies and gentlemen, and my thanks to a lot of you who have travelled far distance to be here. And more importantly, my thank you to the technical team who are projecting this lecture across the web, especially Tim Smale at the top, for my family to have a look at this lecture in India. I hope the technology in India is working, though, because that doesn't necessarily always happen. What I'm going to do today, although my talk is on spasticity, is attempt to set the scene as to why spasticity is important. And in order to do that, I've got to talk to you a bit about motor control. And of course, for those who know me quite well, will find that when I talk about motor control, I like to slip in a reference to something called karate. It's something I spend a lot of time doing when I'm not doing research and I'm not sitting at home. which tends to be more often doing karate than sitting at home. So I will start by talking a bit about motor control. And once we've talked about motor control, we would then talk about what happens to this control when a person has a stroke. Once I've done that and I set the scene for spasticity, I will then take you very quickly through the process of going from the lumper to the splitter. And to be fair, I don't think we have covered the splitting as yet as effectively as I would like to. Of course, in this process of going from a lumper to a splitter, my work has been supported by a lot of friends, colleagues. I would say friends, because when you do research over many years with a group of people, you tend to become friends. And I would like to thank them, and probably I'll finish with the acknowledgements that I would like to share. Okay, so let's look at motor control. Motor control, in my mind, is the ability to perform a task that is constrained by the environment around you. In order to get motor control, you have to be able to activate your muscles. And in order to get that control to be perfect, in addition to activation, you need to be able to inhibit the unwanted activities that happen. So if you take this as a graph, for those who know me, graphs and pictures are routine. And that's the x-axis is lifespan in years. And if you look at motor control as the y-axis, I would call it an arbitrary axis at this point. And I've put some pegs on the axis here, which will make sense when you see the videos. And we have a threshold above which you can actually claim to be independent in activities of motor control. A normal person's life will start where there is almost no motor control. You go through a period where you learn to control your activities. That control then leads you to be independent in activities of daily living. That control then gets better with time. And as it gets better, one would hope, in my own life, my personal wish would be that before that control reaches a stage of dependence, that my life would be ended. And I think, in a way, I would argue that governments of today would be interested in the same model. However, the art of control is quite important, that if you don't practice, if you don't do what you're supposed to do, that deterioration is far more rapid. There is another side to this argument, that if you do keep practicing your arts or whatever you do in terms of control, there is the fact that although the physiological system may deteriorate partially, the ability to deliver the activities and tasks will not deteriorate at all. So in a way, one could accept the fact that from a control point of view, we optimize and improve control over time till a point at which that will change. Of course, there are other models in there, but for today's talk, I think simplifying it to this level would be sufficient. From a control point of view, I will illustrate the act of motor control at this point. This is me out here, and that's Mark, a friend I work with. My task is very simple from a control point of view, hit Mark. Mark's task is very simple, stop me from hitting him. And in this process, what I will show you is what I would consider moderate levels of motor control. I am able to, at this stage, perform the activity of swinging a punch at Mark, but I am not achieving my end task. I am unable to hit Mark. Mark, on his side, is also not achieving his target because he is letting me continue to hit him till the last minute. And if people were watching that video, you'll notice that as Mark's hand came flying towards me, there was a point at which there was a break in the movement. That, although Mark is capable of taking my head off, if that punch had been a fist and it had landed, I would have been knocked clean off, and he'd have achieved his task of stopping me from hitting him. However, now I'd show you another video where it is Mark's turn to hit another gentleman who we will call Mitsusuki Harada. He's our sensei in our organization. Now, this gentleman in this video is 80 years old. He's been practicing this art for about 60 years, and Mark is going to do exactly what I was going to do. Take a chance at hitting him. And I'd like you to have a look at the outcome. More importantly, look at what his hand does as he goes at Mark. There is no difference to the technique that I did, and that absolutely no problem in the arm flying out, takes the person out, there is no break in movement, and that to me is a very, very fine level of motor control. Now, I suspect this would be true of any sport. I mean, I have given my example from karate, but it doesn't matter. Any sport, any activity that requires a high level of motor control, the more you practice, the more effective your ability to deliver that level of control. Now, in life, unfortunately, this control can be affected with a series of adverse events. The particular event that I am interested in is stroke. Strokes normally occur when the blood supply to the brain is compromised and there is death of tissue in the brain. Now, from stroke, there are usually 4 outcomes. The first outcome can be death. I will not worry too much about it, and about 30% of the patients who have a stroke will probably die. However, the remaining 70%, there are 3 other possible outcomes. The first outcome is someone who will have a transient drop in the ability to control movement. At the end of that process, they will recover to almost normal. Unfortunately, only about 10 or less than 10% of the stroke population would have that sort of a profile. The remaining 70%-ish of the stroke population would tend to have some level of disability, so they will have an immediate drop in function soon after the stroke and they will recover some parts of that function. Or, worse still, they will deteriorate after a stroke and continue to deteriorate and go into a state of dependency. Now, when they lose motor control, 2 things happen. Remember, when I started off, I talked about motor control being the ability to activate muscles, but also simultaneously inhibit muscles. So when you have a stroke, your ability to activate muscles is compromised. That results in weakness, the inability to perform activities, fatigue at a quicker rate, and the ability to inhibit muscles is lost. And that loss of inhibition will lead to unwanted muscle activity that is not under voluntary control. So you would have reflexes that are twitching all over the place. And of these unwanted muscle activities, which results from an increase or the loss of inhibition, is spasticity. Now, in my case, I came across this term as I was doing my PhD, and I'll come back to that a little later. But this particular term, spasticity, or the condition called spasticity, is considered very important in the field of neurological rehab. And the reason for this is it is believed that this particular group of patients, i.e. those who do not recover function fully or those who deteriorate significantly, the reason for their state of deterioration or a significant reason for this deterioration is spasticity. So as a result, I would be fair to say in the last 100 years, a significant investment has been put towards the management of spasticity. And the depressing fact is, in the last many, many years, I could count in the fingers of my hand the treatments that have been developed for the management of spasticity. So now, what I will do is take a small digression and kind of briefly describe how an engineer came up to starting to look and work in the field of spasticity. I started my life in a town called Kannur in India. It's a hill station, a step closer to heaven, you walk among the clouds. Absolutely wonderful place on earth. And at that stage, I had absolutely no interest on spasticity or stroke. I was just another kid playing around. After I finished my schooling, I started my work in the field of engineering. At that stage, I met one of my first mentors in my life, someone who tried to convince me that there was a need to use my electrical knowledge and move into a field of what he then called medical electronics. Sensor technology, the ability to go into clinical engineering, managing equipment in a hospital. And he convinced me at this point that at the end of my Bachelor of Engineering degree, I should progress into a postgraduate diploma of medical instrumentation. At this point, I met a young lady. That is the first photograph she gave me. And she was studying and working in a hospital not too far from where I was. I thought, well, fair enough. I could do my degree in medical instrumentation, find a job in the hospital she works, and we'd probably get on and stay together in that town. And with that in mind, I completed my medical instrumentation technology degree. There was a job opportunity in the hospital, and this was the Christian Medical College and Hospital in Vellore. And I went and joined her there for a period of 4 years. I started off at this stage doing a lot of research in what would be called routine hospital management. And while the first year was very exciting, I had about 1,500 beds to manage. We had every department known in a hospital. It was a teaching hospital. The job was very, very interesting and challenging in the first year. But at the end of the first year, once we'd solved the logistical problems, the thrill of the job practically disappeared because there were no breakdowns. If you set up a good maintenance schedule, breaks down, disappear. The intellectual challenge of the job started disappearing. And I started then looking at various opportunities of what I could do with my time. And at this stage, as a part of my rotation, I started looking after equipment in the rehabilitation department of this hospital. What was fascinating is this hospital, when I said state-of-the-art, they were dealing with about 1 million outpatients a year. And when I left in 1993, they would have a patient come in the morning, send them for an X-ray, review their case in the afternoon with an X-ray report on the consultant's desk. I mean, that's something this country is talking about now. This happened in India in 1993 in this hospital. Now, at this particular stage, I went to this rehab department, and the only department that had absolutely no modern technology. They were still using diode valve shortwave diathermies, microwave diathermies, these big bulky equipment with a huge diode transistor inside, and it was fantastic. This whole place used to get warmed up. You didn't need heaters in this place. Diode valves did all of the work. And at that stage, I decided maybe it would be good for me to take a further step and go into the field of rehabilitation engineering. And at that stage, there were various options open to me, and I chose to come to the bioengineering unit at the University of Strathclyde. 2 reasons for it at that point. The first being they had an expertise in electrical stimulation, an area that was related to my interest in using electricity and technology for rehabilitation. And they also, at that stage, had done a lot of work in using FES to make, or attempt to make man walk. And young as I was, I thought FES will make man walk. And I came and joined Strathclyde, and my supervisor, Malcolm Granat, and after a few conversations with him, I quickly realized I don't think we'll ever make man walk in my lifetime using electrical stimulation. Yes, we made some attempts, but at that point I thought that's not going to happen. The second thing that happened at this stage was the fact that while a lot of people wanted to do sexy science, i.e. focus on spinal cord injury, regeneration of nerves, there was a population of patients on whom there was very little being done. And I suspect that is even true today, and that was the stroke population. And within the stroke population, the focus was still, and I presume is still, on mobility. 70% of stroke patients will walk. The focus in hospitals is if we can get them walking, we can discharge them. They completely forget about the hand. And the argument that I would put is if you ignore the hand, the outcomes that we see today, 70% of stroke patients unable to use their hands, is that result. So to me, the biggest gap that was available was the upper limb. And at that stage, I thought, well, we can look at the problems of managing the upper limb with technology in stroke rehab. So my PhD was then looking at using electrical stimulation to prevent complications and facilitate recovery of function in stroke, in the upper limb of stroke patients. And this was also the time when I came across the word spasticity. And after much reading and debate, you'd be surprised if I told you spasticity contributes to about 3 pages in my thesis, which is about 100-odd pages long. That was it. There was nothing else to read. And I thought I'd got a handle of what spasticity was. However, I'm digressing a bit in time because the work that I started on spasticity started a little earlier. But my viva, which was a 2.5-hour session, wasn't about my entire thesis, focused on these 3 pages of my dissertation. So I ended up putting what I would consider 3 pages of a summary of the state of the art of the literature, and I ended up having to defend my entire thesis on these 3 pages. It was an interesting session. I think my supervisor who was sitting in the room was bathed in sweat by the end of that session. Fortunately, all I had to do was a few corrections to a reference list. I had a few secondary references my external didn't like. But at that point, I thought, wouldn't it be nice to get a good understanding of spasticity? And that happened at the University of Newcastle upon Tyne with Professor Garth Johnson, who is here with us today. So let me now start the story of spasticity. I went down to Newcastle just as I was finishing my PhD, and I was interviewed by 2 people, Garth and Helen. Helen's now, I think, the professor of stroke, community stroke in Newcastle upon Tyne. Now, Garth and Helen, along with Mike Barnes, had got a project from Action Medical Research to develop a method to measure spasticity. And I went there and I thought I could convince them that I could do the job. Being an engineer who had an interest in measurements, I have no idea what they thought at the end of the interview. I do remember in the evening getting a call from Garth saying, yes, would you be interested in the job? And I said, yep, thank you very much. And those were the days there was no post-study work visa. If you got a job, they gave you a visa to stay in this country. Not a problem at all. So straightforward, got the job, wandered down and got my visa extended and joined Garth to do this piece of work. Now what I'm going to summarize for the rest of the few of the slides here involved two other people. The first is Chris Price, a clinical colleague who was my contemporary. We both worked on this project together, an extremely intelligent clinician, and one of those few clinicians who allowed me to test his performance. If you look at the kind of work I was doing, was literally testing the hypothesis of whatever I was doing with spasticity based on his understanding of spasticity. And that takes a lot of courage to let someone external to your profession challenge your own practice and behavior. And I'm very, very grateful to Chris for the time and effort he gave me in solving some of these problems. The other was Anil Sharma in Liverpool, who also then allowed us to expand some of our work and funded some of this work to be carried out at Liverpool. Now, I was initially funded. You'll notice my tie has Paddington Bear too. Action Medical Research, the mascot is Paddington Bear. And they have funded a large part of my work, as you will see later in the slide. So to start the measurement of spasticity required then for me to look for a definition. And this was the definition that was open to us. It's called the Lance definition. I shall not read it out to you in full detail. But we started off by trying to unpick this definition. The first thing the definition pointed out was spasticity was some sort of a motor disorder. So it had something to do with this loss of activation or loss of inhibition. It then focused on a term called muscle tone. So this was a definition within a definition. So off we went and had a look at what muscle tone actually meant. Muscle tone in the world of neurology appears to have two definitions within it. The first definition is the resistance you feel when you move a limb. So if you try to move a limb, if it feels very stiff, they would say there is increased tone. The other definition is the readiness of a muscle to act, i.e. the ability to activate your muscle to perform a movement. So this then meant we had two things to measure. We had to measure stiffness in order to look at that component of the definition of tone, and we had to measure muscle activity to look at the second part of the definition of tone. Now, for some reason, this problem I described today in spasticity is not a problem unique to spasticity. I think there are lots of terms in the rehabilitation literature, or even I would say the medical literature, which is very, very poorly described. We then went back to the definition and noticed they focused a lot on the stretch reflex, a tendon reflex, and a stretch reflex. Now, if I were to tell you the stretch reflex and the tendon reflex are exactly the same, they are synonymous terms. Why would they use two different terms in a definition? Doesn't make sense. But they then talked about this reflex being hyperexcitable. Now, hyperexcitable is a nice term. It sounds like you've got a handle of the definition for the term. But as I'll point out to you later, hyperexcitable itself is a very, very loose term. And they then added to that this hyperexcitable reflex would manifest somehow in a form of velocity dependence, i.e. the quicker you move, the phenomena will change. So that was quite nice. We managed to put some thoughts together around the definition. And from that, we thought, okay, we had to measure stiffness and muscle activity, and that could be done quite easily. A lot of the work I do is focused on the elbow, not because the elbow is a specific joint, an important joint. It is actually one of the few joints we understand something about. There are lots of other joints in the human body that are far more complex than the elbow. And we thought if we couldn't get an understanding of spasticity at the elbow, the chances of us getting an understanding in any of the other joints were quite remote. So we developed a device that measured angular displacement. It measured the force. If we then took the limb as clinicians would, and this was the nice thing about this device, it allowed us to measure stiffness simultaneously as a clinician was carrying out an assessment. They would do that, and we could then measure the stiffness of a joint. So we could measure the displacement, the force used to displace, and as a result, look at the relationship, which would give you an indicator of stiffness. And in the terms of spasticity, it meant that if I moved the limb faster, there would be a greater level of stiffness. And the assumption was this greater level of stiffness was attributable to a form of muscle activity. In which case, we had to measure muscle activity. And again, with technology improving at the rate it is, that was fairly straightforward. We had to stick a sensor on the flexors, or the biceps, the muscle in the front of the arm, another sensor on the muscles at the back of the arm, and therefore we could measure muscle activity quite easily. So there was the kit, and we could take measurements. And we had a look at what these measurements gave us. So if I measured, that was the angle. The blue graph is the force we used to move. The green graph is the muscle activity from the front of the hand. And the magenta graph is the muscle activity from the back of the hand. So we took the hand or the elbow from a fully flexed position to a fully extended position very slowly. That's normal clinical protocol. And at this stage, the assumption was there would be no muscle activity and there would be very little stiffness, if at all, any that you would feel. And then we would repeat the same process again very quickly, and there would be a form of muscle activity that was proportional to the velocity of movement. Of course, at this stage, it was quite good. I think the first thing we saw was there was a velocity-dependent increase in muscle activity. That was a good thing. But the difficult thing for me was the assumption that at a very slow movement, there would be no activity. That wasn't true. And this is a phenomena that we have now seen almost consistently in all of our data, that even if you move the muscle slowly, there is a level of muscle activity. Of course, the issue then was how much of this muscle activity would contribute to an increase in stiffness. In some ways, it would appear obvious that if there is increased muscle activity, it should contribute to stiffness. But we thought we still had to check this out quite clearly. And we did that over a period of time. So at this stage, for the sake of convenience, I'm going to condense a lot of my results into a few points. The first time we looked at it again, this is another graph. I've put those two graphs separately. In this graph, I've plotted the angle versus the force, the measure of stiffness. And in this graph, I've plotted the same angle against the muscle activity. The first thing you see, again, the phenomena of slow stretch, muscle activity exists. So this stiffness has two components. A component that's related to the muscle activity, a component that's related to the stiffness due to the joint structures. If I move the arm quickly, there is an increase in muscle activity in two steps. Why a step process? There are physiological reasons for it, but at this stage, I'm not going to go into those details. But the important part was there's a two-step increase in muscle activity, and this increase in muscle activity appeared not to contribute to stiffness at all. So it appears that any contribution from muscle activity to stiffness is not always proportional to the level of muscle activity. So there was another series of experiments from which we were able to explore whether reducing muscle activity always resulted in a reduction of stiffness. And at this stage, if you look at the red graphs here, I've plotted the angle against the force again. The red graphs are the graphs taken when there was muscle activity. And there is a wonderful drug that floats about called botulinum toxin, which I'm told is very good at shutting down muscle activity. And we then measured the same stiffness after we had injected people with botulinum toxin. And you'd notice that in one group of patients, or this particular patient, that stiffness reduced with shutting down muscle activity. So one could infer that in this patient, muscle activity contributed to the measurement of stiffness. However, in this patient, it didn't make a blind bit of difference. So then the issue was, should we be measuring stiffness when, as a measure of spasticity, when the response of stiffness seems to be very confounded? And the reason for that is fairly simple. There is a component of stiffness that happens just at the level of muscle skeletal structure. Stiffness can be influenced by the reflex activity, which should be components of spasticity. Stiffness can be influenced by muscle activation, that is cortical. So at this stage, I decided that stiffness was far too much a confounded measure to be of any use to us. And we decided to leave the measurement of stiffness aside and continue our work on spasticity, focusing on the levels of muscle activity. So what did the muscle activity look like? Now, I will try to go very quickly through the next slides, not because of anything else. All I'll be showing are patterns of muscle activity. There were a group of people who demonstrated. In this graph, what I would show you is the red is the slow stretch, the blue is the fast stretch, so ignore those two graphs. But look at these lines. The magenta is the EMG activity with the slow stretch, and the red would be, or the brown, is the EMG activity with the fast stretch. Here's an example of a patient who had absolutely no spasticity. 10% of our patients we measure have no signs of spasticity at all. They also are the ones who tend to have no signs of active movement at all too. So they tend to be dense flaccid paralysis. Then we realized the Lance definition was probably correct, because there are a group of people who demonstrate velocity-dependent muscle activation. So move the arm slowly, there isn't any activity. Move the arm quick, there is a burst of activity. This activity follows a profile that is very close to the velocity profile. So it appears to be a spinal phenomenon where the level of muscle activity is proportional to the velocity of stretching. And at this point, I want to draw your attention to the word hyperexcitability. Does hyperexcitable mean a greater amplitude of activity, or does it mean a greater duration of activity? There is one more point. Does it also mean the activity occurs earlier? So hyperexcitable is one term, but to quantify that and put a number to it requires us to measure at least 3 parameters. And we'll come back to this bit in a later part of my work. We then noticed another pattern of activity that had a bit of velocity dependence to it. However, it seemed to have a predominant manifestation of position dependency, i.e., when I stretch the limb, the muscle is active, and it remains active as long as there is a stretch on the muscle. There seems to be a lower component of velocity dependence. However, even in this particular case, you will notice that when I increase the velocity of movement, the muscle activity starts earlier. Of course, in the medical system and the physiological system, if you have 2 independent phenomena, the tendency is they will also happen together. And a bulk of the patients we measure tend to have a combination of both forms of activity. Position-dependent activity, which is related to one part of the stretch reflex, velocity-dependent activity related to another part of the stretch reflex. And there were 1 or 2 anomalies where there was an acceleration response that could be seen. I mean, these were seen in very, very few cases. And there was another group of patients on whom the muscle activity will be continuous. Almost in a state of rest, the muscle will be in a state of contraction. So if you look at the patterns of muscle activity, they were very variable and they didn't fully conform to the Lance definition. And at this stage of my research career, where we had done a bit of work there, I then moved to Keele. The children had grown a little older. We had 2 more additions to the family. And rum and raisin, by the way. We couldn't bring them in here. And we had our mascot, Humphrey. Humphrey is a little doll that does various things, travels wherever we go with us. And I joined the team in the School of Health and Rehab, probably one of the few engineers who works in a physiotherapy department in this country. And the research work in spasticity continued. There was a bit of overlap between my work in Newcastle upon Tyne and Keele. And at this point, we had started a work. When the work we started at CREST, if I were to say we started our spasticity-related work in CREST as a novice research team. We had done no substantive research in spasticity up to that point. The first project on spasticity started in 1997, and at this stage in time, there were 4 or 5 internationally recognized groups: Australia, Scandinavian-based, America-based, and in Scandinavia, particularly the Copenhagen group. We then had to ask the question, were we doing the right things? And what we were finding, was there something anomalous with our results, or was this the state of art in the literature? Were other people finding out what we were doing? And was there some agreement between what we were doing and what others had found out? The work that I did here was primarily influenced by 2 of my colleagues, research colleagues Shweta and Sheba. Sheba is here. Shweta is in America, by the way. And also informed by 2 substantive discussions I've had with 2 colleagues, Peter Jones, who's here, and John Brew, who unfortunately is not here. At this stage, that was the team based at Keele. The team at Newcastle, Garth had managed to put in a bid to the European Union, and we had a substantively large team reviewing almost all of the literature on the measurement of spasticity, and that was the SPASM project. And at that point, I met a young researcher called Hermie. Not young, I mean, he's young in mind. And he is someone who has contributed a lot to the work I have done. And at the same time, I got a chance to go to the meet and work with the Copenhagen stroke group, which was organized by Bernie Conway, who was who's currently the head of the bioengineering unit at Strathclyde, because he was quite interested in the work we were doing, and he wanted us to come and present our results, which were quite against what he thought was the norm in the published literature. So this was the time we thought, I'll put some summary together to tell you what the literature told me was related to spasticity. The work I present today is primarily related to Shweta's work on spasticity. Now, Shweta, being a PhD student, I said, go away, do a review. She ran away and did a review, and we had to restrict the review to upper limb and stroke, just because if I did it in any other way, my experience with spasm said she would have had to read about 5,000 papers. Not possible at all. So she ended up identifying 265 articles, and one of the first questions she asked was, what does the literature define as spasticity? Did they use the Lance definition? Was there something else in it? And in answering that question, we found a few interesting facts. Spasticity, or the word spasticity, doesn't arise in the literature till nearly the 60s. The original term was the word spastic paralysis. Now, you'd notice in my first slide I talked about paralysis due to activity reduction, increased reflex activity due to an increase in reflexes. You had spastic, i.e. a muscle that was contracting involuntarily, and paralysis, a muscle that could not be activated. So the first use of the term was spastic paralysis. We then had a definition of these terms by Hewling-Jackson. You've seen that slide earlier. And Denny Brown in the 60s gave a form of a definition which had never taken off, and then there was the Lance definition. So we were right. We had used a definition that was based in the literature. However, if you actually look at the literature, 2/3 of the literature ignores Lance's definition, so it would appear it makes no relevance at all. And even worse was 1/3 of the literature appeared to have no definition for this term. They used this term, they were treating this condition, they were measuring this condition, but they didn't use a definition for this condition. So at this point, we had to ask the next question. If they were not defining the condition, at least did their measurement have a framework of reference that we could work with? And unfortunately, the answer was no. About 15% of the literature measured spasticity as physiologically defined. All of the other literature appeared not to do this. And a lot of this work was informed by two of the researchers I worked with, Frederica Van Wyk and Alex Hoare. Both were based at Newcastle upon Tyne. So I think the conclusion was there was a pretense of a definition, this wasn't an agreed definition, and this definition that we were using didn't inform practice or any form of measurement. And what this also meant was the word spasticity, which was originally considered one of these phenomena related to increased activity, was being used synonymously to indicate all of the conditions increased with increased activity. So the term spasticity, also, although precisely defined, was also being used in a way that was contrary to what the definition was. At this point, we had to go back. Just go back a minute. We had to ask the question, spasticity, Lance's definition talked of reflexes. When we redo this definition, reflexes became an important part of the definition. So we then had to ask the question, whether reflexes are truly abnormal in stroke. Because if all of this phenomena that we're measuring is related to abnormal reflexes, we should be able to measure these reflexes quite easily. This is where the next project funded by Action Medical Research came in. This was a project that was carried out when I was in Newcastle upon Tyne. Again, it was Garth, Chris, and myself who put this project together. And Jose, who was the RA on the project and one of my first PhD students, which I supervised under the mentorship of Garth, came along the way. Poor Jose, I really felt sorry for him. He had to develop a toy to measure reflexes. And we said the conditions are fairly straightforward. You have to give a toy, take the measurements at the patient's bedside, where the patient has absolutely no ability to move, or take measurements when the patient is discharged and the hand is sitting up here. For those who are familiar with stroke, as a person's stroke deteriorates, the ability to put the hand in any position gets very difficult. And so Jose went away, along with the help of Rob, one of our colleagues in Newcastle, developed a little toy that did exactly what we wanted, i.e. a mechanical system that produced a perturbation that we could measure a patient in any position we wanted. We took a lot of the measurements, we used the reflex system, and there is the device. It produces a mechanical perturbation that lasts about 110 milliseconds. That's the time delay required for the reflex activity to occur. and there was a reflex. So we had a system that could measure reflexes, and we then asked the question as to whether the reflexes were hyperexcitable. We quantified reflexes using the amplitude, how big the reflex was, how quickly the reflex occurred, the latency, and the duration of the reflex, how long did the reflex activation last. We compared the data between people who didn't have a stroke and people who did have a stroke, and also had spasticity, or at least were being treated for spasticity. So the belief was they had spasticity. And what Jose found out was reflexes were not necessarily abnormal in stroke. So the amplitude of the reflex, surprisingly, was greater in the non-impaired population. Yes, the latency was a little shorter, and that would tie in with the signs of disinhibition. The rise time and the duration, there was absolutely no difference. So what appears to be happening is the reflexes don't appear to be abnormal in stroke. And that's a bit of research that I had to go back and visit, and this is a bit of work we did with the team in Oswestry, where we looked at the reflex in a child with cerebral palsy who was being treated for spasticity. And again, those graphs I show you are reflex activities measured in the hand and the legs of this child. And if I were to tell you, those graphs show absolutely no abnormality. So although spasticity is a problem and is attributed to a lot of the reflexes or hyperactive reflexes, we are unable to find consistent evidence that all people who show abnormal signs of muscle activity have abnormal reflexes. And this brought together the need for a definition that then unified what was considered state-of-the-art, the understanding of what was happening, the reality of what we were measuring, and that led to the first definition, which came out of the SPASM consortium. We defined spasticity as disordered sensory motor control that presented as either intermittent or sustained involuntary activation of muscles. That seemed to be the only definition that caught everything that was required. Of course, the problem is when you get a definition such as this, if you were to recommend that people use it in the literature, it causes a problem because they never tell you which aspect of spasticity they are measuring. So that with the process of lumping and coming to an overarching and a unifying definition meant that we also then had the responsibility to develop an argument for the component parts or defining the component parts of spasticity. When we were doing this work, there was a team in North America who we tried to engage with to then ask them the question of how they were going about defining spasticity. They had taken the approach of splitting. They didn't bother with lumping at all. They said, we are going to split the definition of spasticity. We had a long conversation with them. We, in fact, invited them to our conference and said, come and talk to us about what you're doing. And the problem we had was they continued to ignore muscle activity. The American team decided to focus on stiffness. To me, continuing to focus on stiffness when the evidence was stiffness as a confounded measure was not good science at all. And so, due to the circumstances, we decided to carry on working independently as opposed to working in collaboration. And at this stage, we went back to the overarching clustering of spasticity and we started looking at the independent components. Increased reflexes, I think I've presented the case, is not necessarily abnormal. So we had to resolve this, and for time being, I've had to park that because I don't think we can give a definition of when is spasticity associated with increased reflexes. The next thing to consider was altered tone. Could this be considered a part of spasticity? If I go back to stiffness, it's a confounded measure, so my answer is no, it can't be. The readiness of a muscle to act or the inability of a muscle to act, I don't think is related to spasticity at all. It's related to paralysis. So from that point of view, we had to take altered tone out of our definition of splitting, or out of the splitting part of the definition. That left us with spasm. Now, spasm can be defined, and there are methods by which spasm can be measured. It's a transient muscle contraction. It appears primarily to have a cutaneous trigger. So the spinal networks related to spasm can be defined. We had clonus, which also can be measured. Now, clonus can be both measured and defined. And one of the scales that is currently being used for spasticity depends on classifying clonus. Now, clonus has either a proprioceptive trigger or a cutaneous trigger. Again, the physiology is explainable. So we could define spasm and clonus as two subcomponents of spasticity, which ties in with the original the definition we proposed earlier. Then we had the final bit, the abnormal movement patterns and co-contraction. This still is causing me problems. If any of you were told to lift a 200 kilogram weight with your biceps, the chances are you will contract almost every muscle in your body. So if you are performing a task that is intensive in terms of strength or intensive in terms of novelty, a new task, learning to dance, if I were trying to learn to dance, it would be terrible. I would probably contract every muscle to a point where my right leg would become a left leg. So in normal physiology, we will abnormally contract our muscles under certain conditions. We make the assumption somehow that after a stroke, that this abnormal activation is a pathology. I am still not convinced the argument exists for it to be a pathology. Until I think we have an argument and clear evidence that that is the case, I would have to park this in the splitting pile. That then leaves us with the patterns of muscle activity we saw. At this place, I'd like to introduce another research colleague with whom I don't do much of collaboration. We both work in different parts of the world. We only meet at conferences, and we have lots of arguments. And these arguments tend to go on late in the night. It's Jean-Michel Gracies, who works in France. We have tried, based on the various patterns we see, to define spasticity, to stay true to the original definition that came out of Lance's work. I must say, although we've put a set of words together, it is still not working. We are still unable to relate these patterns of muscle activity to stretch reflexes. So we still have to agree to disagree. However, within these patterns of muscle activity, there is the clasp knife phenomenon, the acceleration response of the muscle. That we can define quite comfortably and also explain it. The continuous activation of muscles can be defined and explained. That the term they use in literature is spastic dystonia. However, these three patterns is still open to debate. Now, I started my lecture with motor control, so I shall try to finish it with motor control. The whole focus of my work on spasticity started from the assumption that spasticity was somehow a problem. If I take the model again, that was graphical, this is Venn diagram based. If we took environmental conditions, an individual carrying out a task, the ability to carry out the task is what we would call motor control. Now, we assumed at the start of this work that spasticity interfered with this motor control. What we completely forgot to accept and forgot to look at very seriously was the potential that we were testing this individual not when they were doing out a task, when we were doing things to them. And it is possible, it is just possible, that the individual may be producing a set of responses that are related to our stimuli. In which case, what we are measuring is potentially an epiphenomenon. And there is some evidence for that in the work on the data we have collected in another project that we carried out quite recently. Although this particular project was funded by Action Medical Research, it wasn't related to spasticity, but was trying to develop a new method of treating people early after stroke. Now, what I've got in here initially are a group of patients who have not recovered arm function. So these are the patients who sit in the category of no recovery of arm function. We've measured spasticity, and this is the numbers you see there are related to muscle activity. We've measured muscle activity at week 0, 6, 12, 24, and 32 weeks from recruitment. Week 0 is about less than 1 month post-stroke. So the measurements we've taken here could be anywhere between 1 week and 4 weeks post-stroke. And all of them have spasticity. So one could then, based on just this data, infer that spasticity is a bad thing. However, what is the other thing we did in this project is then look at patients who had recovered functional movement. Fascinating, they also had spasticity. And that spasticity, if I look at the amplitude of muscle activity, is much higher. Don't put any weighting to it, but the reality is spasticity exists in people who have recovered arm function. So in my mind, there is a little niggle now. Have we been focusing on a phenomenon and the response we're getting and trying to characterize a phenomenon that probably is not playing a significant role in motor control per se? It may play a role in adding to disability, but I'm not convinced it is playing a significant role in motor control. So I go back here. The wish that I would like to have with our research is to be able to convert these patients to those patients. Patients who, despite severe levels of disability, will recover quite quickly. And that work is being carried out now with a large team, a virtual team, I would say, some of whom are here and some are circulated around, based in Oswestry, Birmingham, and Liverpool. So that's where the research we're doing goes now. I'll finish off very quickly by thanking the various people who've helped me along the way. Garth, thank you very much. It's been a long ride. You're getting bald, I notice, and I notice those lines at the top of your head, and so are the others. But no, thank you very much for a long time. And Hermie, I hope, who's listening online, and John, who's not here at all. I must thank my research colleagues. I know there are lots of you, and to name each one of you is quite difficult. But I do know one thing. There are a few here who have had to bear the brunt of me being a direct supervisor to them. Kath and Liz, who are around here. And this, to me, was an illustration of a drawing one of my students had drawn at the end of a very difficult research lecture I'd given. She said, I felt like this. I presume my other research students who I've supervised feel like this. I hope, if that is the case, sorry. But I think the science you've produced as a result is of very, very high quality. The teams I'd like to mention are the team at Crest, a whole lot of people from Crest, specifically Rob Davidson, who helped us with the design of the device, Ramesh and Tudor Smith in Liverpool. We have the SPASM team and the ATRAS team, in particular Joe and Sib, who are here. We have the UBOS team, the team looking at early intervention in stroke again, trying to look at both reducing spasticity and strengthening the muscle to see what is happening. And I think that project, in my mind, is one of our best projects. We are starting rehabilitation at about 24 hours post-stroke. From an upper limb point of view, that is a very, very good project. I think the first in the world to go that early. The spasticity and muscle-related work that's carried out both with colleagues I've had friendships with in Poland and the NIH, and a whole lot of people who are here, and a whole lot of PG and UG students who do contribute to the research despite what they think they're not doing. There are my colleagues, my teaching colleagues and my administrative colleagues who do a lot of help for me. And as a part of my research, I travel away quite a bit. They take a lot of effort, they stand in for me, and Julie particularly, who's arranged most of the events for today, thank you very much. And my teaching colleagues who step in every time I have to disappear on a research meeting. The funders who have supported our work, Action Medical Research, I'm not sure, they did tell me they are likely to be here today, but if they are, and if any of you see them, if you can support Action Medical Research, I'd be very grateful. And finally, two of my friends who make me realize there is a bit more to life than just work, who I take a lot of time and pleasure working with, and they do de-stress me. Thank you very much, guys. And finally, my family, who have put up with me moving continents, cities, and towns, and who have given up a lot to help me get to where I am. Thank you very much. Thank you.
Thank you, Anand, very, very much. I think we have a little time for one or two questions. So Anand has kindly agreed to take a few questions, and I'm happy to invite the audience to ask him something challenging. Question at the back, sir.
I find it very interesting, but I haven't grasped all that you've talked about. How does it affect directly a person that's had a stroke in mobility?
I think this is the question that we are struggling to answer. We believe, or some people believe, that spasticity may interfere with your ability to walk. However, there is a side of me that says it may be weakness which is a bigger problem. We still haven't teased that out as yet. So I think the answer to your question is still awaited.
Sorry.
The argument that some people who have good function also have spasticity
Yes, I think I have asked this question, probably I've simplified it for the purposes of this talk. I would partly agree with you that having spasticity may interfere with motor control. I am yet to see experiments that have explained that relationship clearly. However, there is another side of spasticity which I haven't addressed fully in here. And this is related to the fact that when a person gets a stroke, the first response is paralysis. At that stage, we are dealing with a muscle that is starting to deteriorate almost from the point at which this deterioration has occurred. In these patients, the forms of muscle activity we have showed you may lead to the muscle being encouraged to remain in a static posture. Again, we haven't studied that very carefully. But we then have the issue of, in these patients, the static posturing leads to secondary complications which may interfere with function. But to answer the question of whether it is just the spasticity we measure primarily using passive methods, somehow preventing a functional movement, I don't think we've research as yet. I am personally of the view that the day we will answer the question will be the day we get a very clever experiment that is modeling what we measure passively as a person recovers the ability to move. And then comparing what happens to this activity as they recover function. Now that experiment has not been done. And it's not an easy experiment to do, because the people I measure here who have levels of function can actually do motor tasks that are fairly complex, pick and place objects. The people who don't have function often are unable to move their hands at all. And the transition as they go from unable to move to being able to move, to test whether it is spasticity, is not as easy. However, in that group that we showed you who had recovered function, there were multiple levels of function. So there were some who were recovering function, and the data I showed you over time, their function improved from little movement to very good movement. So my view is they continue to show spasticity at the same level throughout. And I am still tempted to say it may be an epiphenomenon. I agree we haven't fully answered the question. That work needs to be done. But trying to get funding to do a piece of work and the engineering to look at patients who have no function, who we can then follow with function, is not easy, because that sort of longitudinal studies require substantive funding to monitor people over time. And for some reason, the government funding models think longitudinal studies are not worth funding. So yes, I think partly I may be oversimplifying, but I think the evidence so far is all of our research that has concluded that spasticity is a bad thing has only focused on patients who had no function. And I think they have never ever bothered asking the question, what about those who have recovered function? Do they show the same pattern? And that's what I think we have done for the first time there. I haven't answered your question fully, Garth. With all of the data we have, most of our patients have MRI, and therefore we have a reasonable understanding of the level of stroke. So we have strokes which are lacunar strokes, posterior circulation infarct. So we have the entire range. There appears to be almost no relationship with these abnormal activity patterns and the type of lesion. I think this is the problem. When you talk of motor control, disordered motor control, what we scan of the brain is we have no knowledge of the past history of movement. All we can scan is after the event what happens. Now, there is another problem we have in there. A lot of people make an assumption that MRI and functional MRI give us useful information. They actually give us very, very little useful information. Because a brain is being activated in one place doesn't really mean anything. So if you look at some of the early work carried out by Sherrington, I do apologize for people who have a fear against animal experiments. Some of the early work by Sherrington, he demonstrated quite clearly that you can completely destroy the motor area of a primate, completely destroy it, and the recovery of hand function will occur. and then they go back and try to find out which part of the brain is controlling this recovered arm function, and they've never been able to isolate it. And this is the problem. We're dealing with a nervous system that is extremely plastic and extremely variable. So those who have done the work haven't come out with any clear conclusion.
I think we've probably got time for one more question. At the back there.
Ooh. I know who my friends are now. Yeah. Again, in the groups we have seen, I have had much smaller samples in my study. So if I were to say, is there a relationship between sensory loss and spasticity, we haven't been able to find any in the data sets we have. That doesn't mean it doesn't exist. The difficulty is, it is impossible for us to measure proprioceptive loss as clearly. And that's the one difficulty we have in stroke. Now, for those who are not clear about proprioception, is if I close my eyes and keep my hand in this position and I close my eyes, I'd be able to match my positions quite comfortably, i.e. my ability to put my hand wherever I think the other hand is. To measure that in stroke is very difficult, and we're confounded by the weakness problem. So if you look at sensation as in terms of proprioception, we haven't done the work at all. If you ask in terms of sensation as in cutaneous sensation, again, all we do know is if you see spasms, which is seen in spinal cord injury or the spinal model, cutaneous input seems to trigger spasticity. Is it related to aberrant cutaneous processing? The answer is don't know.
Okay, thank you very much indeed. I think it's always a real pleasure to come to an inaugural lecture and see the insights which come from the new professor in terms of their own research field. And I also find it interesting that in almost every inaugural lecture we have, we end up with far more questions than answers, which I suppose is the sign of good research. And I've certainly been fascinated about the research evidence you've brought of the investigations you've been doing into what is an incredibly important issue for many individuals and many families, many patients. And the progress that you're making in understanding is ruling some bits of understanding out, but raising more questions about how things actually work. So there is no doubt you have many years to come of fascinating research and challenges which are going to be very useful to yourself and to society as a whole. Fascinating lecture, Anand. Thank you very much indeed, and thank you for your contribution this evening. If we could say thank you in the normal way, that would be great. Before colleagues disappear, we have a new tradition as of today with Keele inaugural lectures, and we want to make a small presentation to Anand, just as a memento of this occasion, which we think is an important occasion both for the university and for Anand. So Anand, can I make a small presentation to mark the occasion?
Thank you very much.